Hello everyone, very good evening to all. Welcome to this physiology session where we're going to discuss about the most important questions. So this has been formulated based on the pattern of questions and the pattern of topic that has been asked in the recent years. With me, Dr. Abirami, your physiology faculty. Yes, let's start off the session with this quote that I like a lot. You can't make an omelette without breaking a few eggs. Yes. If you keep worrying about the eggs being broken, then you will never be able to taste a good omelette. So that's how sometimes, as far as your exams are considered or life is considered, you should know where you should worry and where you should not worry. You can't keep crying about the eggs being broken if you want to taste a good, tasty omelette. So let's move on to the question as such. The first question, this has been a repeatedly asked topic, especially for your INI-CET paper. I've seen this question for NDS dental exams as well as NEET PG exams. Auditory pathway is a very favorite topic for AIMS people. So there was also a recent MDS paper question on this. Identify the correct statements regarding the auditory pathway. So the question is about the auditory pathway, the hearing pathway. The answer to this question is potassium influx causes depolarization. But let's quickly go through the auditory pathway, the basic physiology mechanisms, and then we'll come back to this question. The hearing mechanism. How are we able to hear? When sounds enter into your ear, the sounds enter into the external ear, then into the middle ear, and then into your inner ear. Inner ear has two important structures. This is the cochlea, which is responsible for hearing, and we also have the semicircular canals, atricle and saccule, which are responsible for balance and equilibrium. Together they are called vestibular apparatus. So the vestibular apparatus is made up of semicircular canals, atricle and saccule. They help with balance mechanism. Semicircular canal, it mainly helps to respond to any head rotations. For example, you go on a roller coaster, there's a head rotation. So that will be helped by, the balance is helped by semicircular canals. Atricle help you with horizontal acceleration and saccule helps with vertical acceleration. So that's about the hearing and the balance mechanisms of the ear. Hearing, as far as hearing is considered, it's all because of the cochlea. So that round and round snail-like structure, this is your cochlea. Now let's zoom into the structure of the cochlea. So in the structure of the cochlea looks like this. Cochlea has two membranes. The top membrane is called the Reisner's membrane and below basilar membrane. These two membranes are dividing the cochlea into three divisions. So the divisions are the top scala vestibuli and below scala tympani. The fluid contained in scala vestibuli and scala tympani is called perilymph. Perilymph, maybe they are outside, peri. And they are rich in sodium. The scala media, the fluid in scala media is called as endolymph, and endolymph is rich in potassium. This is very, very important point because this is what the question. Potassium influx is responsible for the endocochlear potentials because scala media is rich in potassium. This potassium only, when sound vibrates your basilar membrane, the vibration of this basilar membrane vibrates your hair cells. So these are the hair cells. When the hair cells are vibrating, this potassium enters into the hair cell. Potassium influx into the hair cells. Usually there is a sodium influx everywhere in the body, but only in this portion you have potassium influx. Potassium, usually it's a potassium efflux. Why here alone it is a potassium influx? Because all this is happening in the scala media, and scala media is rich in potassium. and the endolymph is rich in potassium. And who is responsible for secreting this potassium? Stria vascularis. You can see the yellow colored cells here. These yellow colored cells secrete potassium into the scala media. So the potassium is contributed by the stria vascularis. Now let's zoom into this structure, the basilar membrane. On the basilar membrane, this important organ is called the organ of Corti. Organ of Corti contains the hair cells. If you zoom into the structure of this organ of Corti, it looks like this. This is the organ of Corti. Where is the organ of Corti located? On your basilar membrane. So on the basilar membrane, the organ of Corti is made up of hair cells. Very, very important, because hair cells only contain the receptors for hearing. On top, the hair cells are connected to the tectorial membrane. The other parts of the organ of Corti, they have supporting cells, dater cell, pillar cells, and this structure is connected to the hair cells, especially they are connected to the nerve. Which nerve? Auditory nerve, the cranial nerve, 8th cranial nerve. It's called the vestibular cochlear nerve, which is responsible for hearing. Now, whenever sounds enter into your ear, so the sounds will vibrate the basilar membrane. When the basilar membrane vibrates, this basilar membrane will push on the hair cells. The hair cells are of 3 orders: shortest one, tallest one, and the middle ones. Shortest hair cells, they are called as stria terminalis. They are called as the stereocilium. The tallest ones are called as kinocilium. When the basilar membrane vibrates, it will push the stereocilium towards the kinocilium. When the stereocilium is pushed towards the kinocilium, they are all connected by tipplings. The tippling opens and therefore cation channels open. The movement of the tippling opens up cation channels. So when the stereocilium is pushed towards the kinocilium, there is opening up of cation channels and a cation enters inside. Which cation you think would enter inside? Potassium. Yes, because here it is the potassium influx. Elsewhere in the body, it's always the sodium influx. In some places, you also have calcium influx, but in hearing mechanism, it is the potassium influx, because all this is happening in the scala media, and scala media is rich in potassium. The entry of this potassium. Potassium is a positive ion. When a positive ion enters inside, whenever you have a positive ion, there is a depolarization, and this results in action potentials which trigger the cranial nerve 8, vestibular cochlear nerve, and this 8th cranial nerve takes all these impulses into your auditory cortex. Auditory cortex is located on the temporal lobe, and that's exactly called as the auditory pathway. What is the mnemonic? Ecolema. E for 8th cranial nerve, C for cochlear nucleus, O for superior olivary nucleus, L for lateral lemniscus, I for inferior colliculus, M for medial geniculate body, and A for auditory cortex. And this is called as the ecolema pathway. This is the auditory pathway. This was a INI-CET repeat question. The sequence was given in a different order. The question was arrange the sequence in the correct auditory pathway. So ecolema was a repeat question. Now moving back to the question. Now see if you are able to answer this question. Identify the correct statement regarding the auditory pathway. Potassium influx causes depolarizations. Yes, because scala media is rich in potassium. Look at option A. Hyperpolarization induced potentials. Hyperpolarization induced potentials play a very important role in the visual pathway, not in the auditory pathway. Look at option C. Endocochlear potentials are due to sodium ions, not sodium ions, but they are due to potassium ions. So which is correct? Only option B is right. So we go with option B. Over to second question. Which of the following event succeeds first heart sound in cardiac cycle? The right answer would be isovolumetric contraction. So this is a very important question on cardiac cycle. Only if you know the phases of cardiac cycle, you will be easily able to understand this question. So quickly, let's go through the phases of cardiac cycle and then we'll come back to this question. So this is the diagram for cardiac cycle. What is your basic understanding of cardiac cycle? What is cardiac cycle? Every time your heart beats, what is the pressure change and volume change happening inside the heart? That's called the cardiac cycle. So let's do that. That is why in the diagram of cardiac cycle, you have the pressure axis and volume axis, because cardiac cycle is the pressure change and volume change inside the heart. Now, in pressure axis, there are three pressure curves. How do we identify these curves? There are three curves. Look at the topmost curve, this one. And let me trace this in green color for you. I'm just tracing it in green color. This topmost curve in green color. This one. How do you identify this curve? Look at the pressure variations of the curve. It almost starts at 80 millimeter of mercury and goes up to 120 millimeter of mercury. So the pressure variation is 80 to 120. What is 120/80? Your normal blood pressure is 120/80. Which blood vessel is the origin of this pressure? Which is the first blood vessel which comes out of the heart? When heart pumps blood, blood enters into the aorta. So what is 120/80? It is actually the pressure developed in the aorta. So in cardiac cycle diagram, if you see a curve where the pressure varies between 120 and 80, it means it belongs to the aorta. So let me label this as aortic pressure curve. Aortic pressure curve. That's another huge curve in red color. Very big curve. Look at the pressure variations from 0 to 120. Such huge variations in pressure, only a huge chamber can produce. Which is that biggest chamber in the heart? Your ventricles. So whichever curve is big, it will belong to the ventricle. So let me relabel the red colored curve as ventricular pressure curve. There's another small curve. Let me trace that in black color now. This one. Small curve. And you can see the pressure variations. It is not even reaching 20. Very much less than 20. So very small changes in pressure. Only a small chamber can produce small changes in pressure. Which is a small chamber in the heart? That is your atrium. So this is atrial pressure curve. So we have three pressure curves: aortic pressure curve, atrial pressure curve, and ventricular pressure curves. Over to volumes. There is only one volume curve, the blue colored curve. Which volume change is more important for us? Atrial volume change or ventricular volume change? Definitely the ventricular volume change. So that's why the volume change in the ventricle only has been given in this diagram. So there's only one volume curve which belongs to the ventricle. So I will label this as ventricular volume curve. Ventricular volume curve. So that's how you identify pressure curves and volume curves. Now over to phases of the cardiac cycle. What is the easiest way to learn the phases of the cardiac cycle? What is the cardiac cycle? Every time your heart beats, for every heartbeat, the pressure and volume changes. What is one heartbeat? Your heart is contracting. See, if the heart is contracting, it means there's a contraction and there's a relaxation. So when you have a contraction and a relaxation, that's called systole and a diastole. So what are the phases of cardiac cycle? Systole and diastole. And we also have atrium and the ventricles. So we have atrial systole, atrial diastole, ventricular systole, ventricular diastole. So in that order, we will label this. So the first phase, atrium. So this belongs to atrial systole, followed by atrial diastole. But remember, atrial diastole is a very insignificant event. So we are not including that into this. Negligible. Next, let's move on to ventricle. This is ventricular systole, followed by ventricular diastole. That's how we identify the phases of cardiac cycle. Now, let's fit the valvular events into this. Just imagine atrium is contracting and pushing blood into the ventricles. So if this atrium is contracting and pushing blood into the ventricles, which is that valve which is present between the atrium and the ventricles? Yes, this is the AV valve. So when atrium contracts and pushes blood into the ventricles, after this event, AV valve will close. Yes, ventricle is filled, so AV valve closes. So in the cardiac cycle diagram, this is atrial systole. At the end of atrial systole, AV valve closes. So the event happening there is AV valve closure. So I'll mark this as AV valve closure. When the AV valve closes, the ventricle is filled with blood. Now, the ventricle has to send this blood into the aorta. If it's the left side, it has to send this blood into the aorta. So, we draw this aorta here from the left ventricle. This is the aorta. And the valve which is present at the origin of aorta is aortic valve. This is aortic valve. So now, when the ventricle is filled with blood, this ventricle is going to send this blood into the aorta. So if this ventricle is going to push the blood into the aorta, aortic valve has to open. So now the aortic valve opens. So the next event is aortic valve opening. So AV valve closes and aortic valve opens. But in between these two phases, AV valve has closed, aortic valve is just going to open, not yet open. You have a small phase where both valves would be closed. AV valve is closed, aortic valve is not yet open. Both valves are closed. If both valves are closed, there is no outlet for the ventricle. So the volume in the ventricle cannot change. That's why this phase is called isovolumetric phase. I'm just marking that in yellow color now. This one. So the yellow phase is isovolumetric phase. This is followed by systole. Systole means contraction. So it is called isovolumetric contraction phase. At the end of isovolumetric contraction phase, aortic valve opens. Once the aortic valve opens, blood is pushed into the aorta. So ventricle is contracting. That's why ventricular systole and blood is pumped into the aorta. Aortic pressure is rising. After the blood has gone into the aorta, aortic valve will close. So now the aortic valve closes. Aortic valve closes. Now for the next cycle, again AV valve opens. AV valve opens. But here also you have a small phase where aortic valve has closed. AV valve is not yet open. It is just going to open. A small phase where both valves will be closed. If both valves are closed, there is no outlet for the ventricles. So the volume in the ventricle cannot change. Again, it is called isovolumetric phase. Again, that becomes a isovolumetric phase. But now it's called isovolumetric relaxation phase. At the end of isovolumetric relaxation phase, AV valve opens. When AV valve opens, blood is pumped into the ventricle. So ventricle is going to dilate. Ventricular diastole. This is followed by ventricular diastole. Ventricle is getting filled up. So the question is about heart sounds. When do you hear first and second heart sounds? So first and second heart sound are normal physiological heart sounds. They are heard due to the closure of the valves. Closure of AV valve gives rise to first heart sound S1. Closure of aortic valve gives rise to S2. So the question is, at the end of first heart sound, what is the succeeding event? What is the next event that is happening? Isovolumetric contraction. Immediately after S1, after the first heart sound, the succeeding event is isovolumetric contraction. So if you move back to the question, which of the following events succeeds the first heart sound in cardiac cycle after the first heart sound? That is isovolumetric contraction. Similarly, which is the event that succeeds second heart sound? Then the answer would be isovolumetric relaxation. So that's how we understand this question. Cardiac cycle itself is a very, very important question. in physiology as well as medicine. Let's move on to the next question, question number 3. Glucose is reabsorbed by which type of transporter in the apical membrane of PCT, proximal convoluted tubule? This is very important because there are two membranes in the proximal convoluted tubule. Not only the PCT, the entire entire tubule has two sides. What are the two sides? Let me draw a nephron. So if this is the glomerulus and the tubule, if this is the proximal convoluted tubule, this membrane, which, so let me draw a portion of this. So this membrane which faces the urine, so this is going to flow out as urine. PCT, DCT continues as the urine flow in the along after the collecting tubules. This is the apical membrane. The urine facing membrane is called apical membrane or the luminal membrane. The other membrane which faces the blood facing side is called basolateral membrane. So there are two sides. So if you take the proximal convoluted tubule or any part of the tubule, there are two sides, apical membrane and the basolateral membrane. Now what are the transporters present on the apical membrane and basolateral membrane for glucose? So glucose is transported by two type of transporters, SGLT2 on the apical membrane and GLUT2 on the basolateral membrane. So if glucose is filtered and if it enters into the tubule, this glucose will be reabsorbed into the blood through these transporters. So on the apical side, it is sodium glucose cotransporter, which is an example for secondary active transport. But on the basolateral side, it is GLUT2. GLUT2 is an example for facilitated diffusion, which is a type of passive transport. So it is SGLT2 and GLUT2. So that's how glucose absorption occurs. What is the clinical importance here? In pharmacology, we learn about SGLT2 blockers, gliflozins, canagliflozin, dapagliflozin, empagliflozin. These are all drugs which block SGLT2. If you block SGLT2, you are blocking glucose absorption into the blood. So blood level of glucose comes down. That's why gliflozins are used in the treatment of diabetes. They are anti-diabetic drugs, oral hypoglycemic drugs, gliflozins. So moving back to the question, glucose is reabsorbed by which type of transporter on the apical membrane? Yes, it's secondary active transport. If the question is basolateral membrane, then the answer would have been facilitated diffusion. Question number 4. Dromotropic property of heart is related to dromo. Drome means conduction. Dromo means conduction. So this is conduction. Dromotropy means conduction. Let's learn the other properties also. Ionotropy. So you remember like this. Ion means force. So that's force of contraction. Lusitropy. Lose means relax. So that is force of relaxation. Chronotropy. Chronology means time. What happens over time in the heart? Heart rate, beats per minute. So that's over time. So heart rate. Chrono means heart rate. Bathmotropy. Bath. When you take bath, you are so excited. So excitability. Bathmotropy, excitability. Dromotropy. Drome means conduction. So dromotropy refers to conduction property of the heart. Over to the next question. Protein C activation causes. So first let's understand what is the role of protein C. So this is called the fibrinolytic system. How a fibrin clot is lysed. First let's learn how a fibrin clot is formed. Then let's learn how it is lysed. So first the clotting pathways. So we have extrinsic pathway, intrinsic pathway and a common pathway. First, let me show you the steps in the common pathway. So the common pathway is factor 10, which is activated to factor 10A. This is the common pathway. And there are two pathways leading into the common pathway. extrinsic and the intrinsic. Extrinsic system. So this extrinsic system, this includes only two factors, TPL, tissue thromboplastin, and factor 7, which is activated to factor 7A. So TPL, tissue thromboplastin, and factor 7. Only two factors are involved in extrinsic system. What is this TFI? This is an inhibitor, tissue factor inhibitor. It is an inhibitor of extrinsic system. TPL, this would activate the extrinsic system, whereas TFI, tissue factor inhibitor, inhibits the extrinsic system. That's about the extrinsic pathway. Intrinsic pathway. Intrinsic pathway starts with factor 12 being activated to 12A, factor 11 being activated to 11A, factor 9 activated to 9A, and factor 8 activated to 8A. These are all the factors which are involved in the intrinsic pathway. Now, in this step, extrinsic, intrinsic, both the pathways unite and they form the common pathway. The common pathway is factor 10 being activated to 10A, then factor 5 is activated to 5A, and there's also the role of calcium and phospholipids. The next step, prothrombin activated to thrombin. Thrombin converts fibrinogen into fibrin, and fibrin is the clot. Who will stabilize this clot? Factor 13 stabilizes this clot. That's why factor 13 is called stabilization factor. So in this, there are two important diseases related to the clotting factors. Factor 8 and factor 9. Factor 8 deficiency is called hemophilia A, and factor 9 deficiency is called hemophilia B. These are the two types of hemophilia. Now, so we have learned how a clot is being formed. Now let's see how do we lyse this clot. By mistake, if a clot is formed inside your body, who will lyse the clot? The direct factor which lyses the clot is plasmin. Plasmin only lyses the clot. Now, what are all the factors which help in activation of this plasmin? To start with, thrombomodulin and thrombin, they activate protein C and protein S. TPA and UPA. TPA means tissue type plasminogen activator and UPA means urokinase type plasminogen activator. So with the help of all this, plasmin lyses the clot. Plasminogen is converted to plasmin and plasmin lyses the clot. If you want to form a clot, you have to activate the clotting factors. But if you're going to lyse a clot, you have to inactivate the clotting factors. So what are the clotting factors which are inactivated in this pathway? Clotting factor 5 and clotting factor A, because we are going to lyse a clot. So if you want to destroy a clot, at least two clotting factors you have to inhibit, factor 5 and factor 8. What is the clinical importance of learning all this? We have drugs which act as fibrinolytic agents. So we learned about this TPA and UPA. We have recombinant form of drugs which are recombinant forms of TPA and UPA. What are the drugs? Streptokinase, altiplase, reteplase, urokinase. So for which disease you are going to use these drugs? If by mistake a clot is formed inside your body, you can use these drugs to lyse a clot. What are the conditions where you have a clot formed inside the body? Yes, it could be a heart attack, a clot inside the heart, myocardial infarction, or a stroke patient where there's a clot in the brain. So for MI and stroke, we can use these fibrinolytic drugs. Going back to the question, protein C activation. So protein C is activated in the fibrinolytic pathway. In fibrinolytic pathway, factor 5 and also factor 8 are inactivated. So in this question, we can go with the answer, inactivation of factor 5. Over to the next question. Myenteric plexus in GIT controls. So the question is about enteric nervous system. What are the divisions of enteric nervous system? Enteric means your GIT, intestines. So the GIT is specially supplied by the enteric nervous system because this is not present in any other part of the body, only in your GIT. The two divisions of enteric nervous system are Meissner plexus and myenteric plexus. Meissner plexus, what are the functions? There are two S here. S stands for present in the submucosal layer, another S for secretions. So Meissner plexus present in the submucosal layer, responsible for secretions. What about myenteric? Myen means muscle. So this is present in the muscularis layer. What will the muscle do? It will move. It will help in movement, motility. So this helps in motility. So GIT secretions are because of Meissner and motility is because of myenteric. And the other name for myenteric plexus is Auerbach plexus. Auerbach plexus. So myenteric plexus helps in, yes, GIT motility. Question number 7. How much is the total dead space in healthy individuals? See, as far as healthy individuals are considered, there are two types of dead spaces: anatomical dead space and alveolar dead space. So I can say total dead space is equal to anatomical dead space plus alveolar dead space. The normal value of anatomical dead space. Anatomical dead space means the air that occupies your trachea, bronchi and bronchioles. It is normally 150 ml plus alveolar dead space. See, we call this space of trachea, bronchi and bronchioles as anatomical dead space because this air is not helping you in respiration. Because there's no alveoli. Your trachea, bronchi and bronchioles do not have alveoli. So since there is no alveoli, the 150 ml of air that is locked in this space, there is no respiration. It can't do respiration. It's a waste of air. That's why we call it as a dead space. It becomes a dead space. So whichever air is not taking part in respiration becomes a dead space. So that's why this part becomes a dead space. So it's called anatomical dead space because anatomically trachea, bronchi and bronchioles are not meant for respiration. They become anatomical dead space. Now, the remaining air moves into your lungs. It moves into the alveoli. So if all your alveoli are functioning properly, there is no alveolar dead space. But if you are a smoker and the smoke dust has destroyed this alveoli, this particular alveoli has been destroyed by the smoke dust. Now, whichever air enters into this alveoli cannot take part in respiration. Why? Because that alveoli has been destroyed by the smoke dust. Any air that cannot take part in respiration becomes dead. So this is the dead space in the alveoli. So it is called alveolar dead space. So who will have alveolar dead space? Only smokers will have alveolar dead space. Or if you have any disease of particular alveoli, if any alveoli is damaged, you will have alveolar dead space. Otherwise, you will not have alveolar dead space. The normal value of alveolar dead space is 0. But if you are a smoker, you will have alveolar dead space. So normally, if all your alveoli are functioning properly, there is no alveolar dead space at all. So alveolar dead space normal value is 0. This is a normal person, healthy person. So total dead space is equal to anatomical dead space plus alveolar dead space. But if your alveolar dead space is 0, then anatomical dead space is 150 ml. Total dead space is also 150 ml. Both are equal because the other value is 0. Even if you add 0, 150 plus 0 is 150 only. So in any healthy person, anatomical dead space 150 ml. Total dead space is also 150 ml. So how much is the total dead space? 150 ml. But this is not applicable to any respiratory disease, only for healthy individuals. If you are a smoker, if any of your alveoli is damaged, then this is not applicable. Question number 8. Diffusion related to oxygen transport across the respiratory membrane is an example of. See, whenever gases move across the respiratory membrane, they don't need any carriers, they don't need any transporters. Oxygen just moves simply across the membrane. That's called simple diffusion. Why there is no transporter for oxygen? Just think of a transporter for oxygen. If suppose the transporter reaches a Tmax value and gets saturated, oxygen cannot be transported. The person cannot breathe. The person will die. That is why by nature itself, oxygen and carbon dioxide transport across the respiratory membrane are examples for simple diffusion. They don't need any carrier protein. There's nobody to carry them. Simply they can go across the membrane. It's called simple diffusion. It's a type of passive transport. Residual volume is the volume of air in the lung after. Okay, let's quickly go through the lung volumes and capacities, then we'll come back to the question. So when we learn the lung volumes and capacities, this is the spirometry graph that you see. Spirometer is a tube. You put the spirometer tube into your mouth, and if you breathe into the tube, the machine will record all these values for you. So let's say tidal volume. What is tidal volume? This small portion of the graph is tidal volume. It means if you breathe normally, during a normal quiet breathing, how much of air goes inside and comes out? That's called tidal volume. So it should be effortless. If you put any effort, that's not tidal volume. Even when you're sleeping, you're breathing. That's tidal volume. So we breathe around 500 ml. So tidal volume during inspiration is 500 ml, during expiration is 500 ml. At the end of this tidal volume, now if you do a forced breathing, inspiration, 500 ml has gone inside. At the end of tidal volume, you take a deep breath like that. 2 liters of air can go inside. That's called inspiratory reserve volume of 2 liters. Now, let's do a forced respiration. At the end of 500 ml moving out, at the end of normal expiration, you do a forced expiration. Like that, if you breathe, you can send out 1 liter. That's called expiratory reserve volume. Inspiratory reserve volume was 2 liter, but expiratory reserve volume is only 1 liter. Why is that? What happened to the remaining 1 liter? It stayed inside your lung itself as a residue. So that becomes the residual volume of 1 liter. So even at the end of maximum expiration, some volume of air is not coming out. It is staying in the lung itself as a residue. That's why it's called residual volume of 1 liter. Moving back to the question. Residual volume is the volume of air in the lung after maximal expiration. Even after a maximal expiration, this air didn't come out. It stayed in the lung itself as a residue. Question number 10. Which of the following is inversely related to stroke volume? First, let me write the formula for stroke volume. Cardiac output is equal to heart rate into stroke volume. Stroke volume means every time your heart is striking, how much of blood comes out. That's called the stroke volume. So cardiac output is equal to heart rate into stroke volume. Now, what are the factors which affect stroke volume? Stroke volume means your heart is striking. Stroke, for every stroke. Stroke means contraction. Your heart is contracted. So the first factor which affects stroke volume is contraction. More the contraction of the heart, more is the stroke volume. So this is directly proportional to stroke volume. If stroke volume is more, cardiac output will be more. It means more the heart contracts, more the blood comes out. Number 2. Stroke volume depends on preload. Preload means you are loading the heart. So if you want to load the heart, who will load the heart? Who will load blood into the heart? Veins only will bring blood into the heart. On the right side, you have IVC and SVC. On the left side, you have 4 pulmonary veins. So anyways, venous return. Veins are only loading the heart. So preload means venous return. So more the preload or more the venous return, more the blood will come out. So this is also directly proportional to stroke volume and cardiac output. Number 3, afterload. Afterload means what comes out of the heart. Heart was filled with blood, that's the load. Now the blood is going to come out of the heart. So how will the blood come out of the heart? Through the aorta. So what is afterload? The load is coming out through the aorta. So afterload means aortic pressure, the pressure in the aorta. Say if I increase the pressure in the aorta, if I close the aorta, blood cannot come out. But if I release the pressure in the aorta, blood can easily come out. So this afterload, which is otherwise called aortic pressure. How is this related to stroke volume? More the aortic pressure, less the blood comes out. So this is inversely proportional to stroke volume and cardiac output. So more the aortic pressure, blood cannot come out. Stroke volume decreases, cardiac output also decreases. So these are the factors which affect stroke volume. Moving back to the question. Which of the following is inversely related to stroke volume? Afterload is inversely related to stroke volume. Whereas preload, contractility and end-diastolic volume. What is end-diastolic volume? Preload. Preload means veins are filling the heart. So when the veins are filling the heart will go into end-diastolic volume. So preload only is end-diastolic volume. So that's also directly proportional to stroke volume. So here the best option that you can choose is afterload is inversely related to stroke volume. Yes, that completes our discussion on the most important question discussion for the upcoming exam. Thank you so much for joining with me in this session. So one thing that I would like to tell you is before your exams, revise as much as possible, because if you read one time, your brain is not converting things into long-term memory. It will fade away as a short-term memory. So even if you read less, even if you read few subjects, you are not able to cover all the subjects, it's okay. Even if you are reading less, but you have to revise the same topic again and again. It is always not about how much you learn. It is about how well you learn for your exams. So be crazy, be stupid, be silly, be whatever you want, because life is too short to be anything but happy. Thank you so much for joining with me in this session, and good night to all of you. Thank you.